Can you see me okay, David? And you can hear me?
Yep, I can see you, hear
great.
you just fine. I'm assuming the rest can as well.
All right. Good afternoon and welcome. Thank you for joining us for our July faculty development session. I'm Dr. Jessica Seaman, Academic Success Consultant for GME and co-chair of the Creighton Alliance Faculty Development Committee. Our committee strives to create and deliver effective sessions that develop our diverse faculty, which is you, as leaders in clinical care, medical education, and research excellence. Our presentation today is Progression Toward Independence. Is this learner ready? By Dr. David Wisinger. Dr. Wisinger is a professor of medicine and assistant dean of faculty affairs for the Creighton School of Medicine and chairman of the Department of Medicine at Valleywise Health. He is also widely recognized for bringing excellence and innovation to Arizona's healthcare sector through patient care, education, research, and community service. Just a few housekeeping items as we get started. We will be recording this session for future reference, and we invite you to submit any questions in the chat, and you can do that directly to me so that it doesn't interrupt the flow for other people. So direct questions in the chat to Jessica Seaman. And then I can monitor those throughout the presentation, and also we'll answer as many as we can by the end of the session. There will be a short 3-question survey emailed to you along with the recording to help us in providing future sessions. Thank you in advance for providing your feedback. Also, this session is eligible for continuing education credit, and you will receive the website and activity code with that email communication from Creighton Alliance, and that will be going out early next week. So Dr. Wisinger, if you're ready, I'll go ahead and turn it over to you.
Sure, thanks, Jessica. Welcome, everybody. And as most people know, when I do give educational sessions, I never take an hour. I never take 50 minutes. Typically, I go much less for 2 reasons. One is I can't listen to myself for 20 minutes, and certainly you can't either probably, and also to allow time for some more interaction, which is difficult in this format of Zoom with chats and so forth, and hopefully we'll be going live, if you will, relatively soon, although I think that's to be determined. Anyway, thanks for coming. We're going to talk about progressing towards independence. Is this learner ready? In other words, the real intent behind this, the real intent behind this is how it is we use some of the more current and contemporary approaches to learner assessment that's different than what we had before. We're going to go through some terms such as milestones, competency, and trustable professional activities, and go over Miller's pyramid, et cetera. The intent behind this is not to get into the deep dive, not to have you become intensely capable of using these terms with great facility, although if you do and you know that already, that's great. But these are terms that are often used in the context of progressions committees in residency training and in other learner training. But I'm having it out there because, quite frankly, a lot of resident assessment and learner assessment, I really should say, is done by people who are not part of these committees and therefore need to have some facility with these terms. So this could really be covered in a much deeper, longer session, not meant for today. I also want to make sure that you as faculty, at whatever level you are within the Creighton University School of Medicine faculty group, and no matter how many learners you come across, that you know that the faculty department and the faculty development group is really available to you at any time for guidance and for resources, and I would encourage you to do so. And if you want to start with me and Jessica, Dan Gridley, Nicole Piamonte, et cetera, by all means, please reach out to us. We're always available. We'll cover a few vignettes towards the latter part of the session here to kind of give you a sense as to what tools are being used to assess learners. This is not meant to have your head explode. We're not learning new languages that are dramatic. And I must say that, can't I tell they're just ready to progress? The answer collectively is no, but there is an element of nuance to this, which we'll go over here in a second. So I'm not totally dismissing that thought, particularly of us older educators. So is this learner ready? The question is, ready for what exactly? Are they ready to, quote, go to the next level, whatever that level is? Are they ready to play a doctor, nurse, therapist, fill in the blank as to whatever it is that you're entrusted to teach? Are they ready just to satisfy me or you? And again, that's not really appropriate because what makes us satisfied obviously is very different. Are they ready to keep learning? We hope that's the minimum. Are they ready just to stop talking, stop embarrassing us, stop making me want to consider my career choice? That actually may be what you're thinking when you're listening to some learners, but not necessarily what we're wanting them to satisfy. So in the old days, and yes, I can use that term, the old days, how did we do what we did? Some of you may remember the novel, The House of God. And by the way, Samuel Shem was a pseudonym for a psychiatrist who actually wrote this book. Very interesting, entertaining reading, best to read if you're in your learner phase, but also good to reflect upon it. But if you look back some of the old days, the question was, and certainly for me, and I bet some of you who are on this, who are of my age group and underwent training during my period, if you will, who was really watching us? And back then, from a faculty perspective, if you told the faculty something, they kind of just took it at face value. They didn't have an EMR to check. Quite frankly, they weren't that concerned about checking medical records. And they obviously many times just trusted what you said. Or if you were a sharp resident who didn't want to get the things sidetracked, you sometimes wouldn't say things. Remember when you used to say, well, as a faculty member, call me if you need me, but don't really need me, right? House of God was a required reading. And the thing that I always think about today, and as I've grown through this, is that it's interesting for those of us who trained in older ways and older days are now in positions to, quote, know how to teach in a contemporary way, yet I'm not sure we've all been instructed on how to teach similarly. So I think there's a lot of variance out there. And the intent today is to try to reduce some of that variance, but recognize there's tools out there that'll make us better at what we do. Yes, back in the day, you just kind of took it as a learner and you just said, thank you, sir, may I have another? And I guess I shouldn't be showing the slide too much longer with Jessica's telling me here. Okay, so today is different. Contemporary medical educators recognize that a competent trainee not only needs sound biomedical knowledge and technical skills, but needs to be able to communicate and collaborate and behave in a professional manner. Again, something that was rarely thought of and certainly rarely articulated and measured many years ago. We recognize that as professionals in healthcare, whatever sphere you practice in, you need to be actually a human. You need to be able to collaborate and communicate. Those were skill sets absolutely not enhanced back in the day. So measurements of skills and knowledge and abilities is fine that we've used in the past, but we need to kind of incorporate some more updated and more nuanced assessment tools to get to these competency-oriented assessment environments. So how do we know this learner is really progressing? Reality is much of what we do is calendar-based. There is a working assumption that 12 months is a period of time when learners can go, quote unquote, to the next level to be entrusted to perform certain clinical activities. We all know that that may happen in 8 months, it may happen in 12, it may happen in 15. It's not finite, although when we talk about milestones, there's an intention there to try to put some calendar time to guide people to advancing to the next level. But the reality is 12 months is kind of an artificial thing. It just is what it is. How do I know this learner is progressing? Because I'm no longer frustrated listening to the learner. Sounds kind of facetious. I know that's why I said it. But in actuality, when you're more comfortable working with learners, that's probably telling you that they're making some progress. Or maybe you're making progress just being as a more compassionate teacher. I'm not sure which. Okay, sometimes I think I can just feel or tell when the learner's ready. And to kind of paraphrase what happened with Justice Potter Stewart back in the 60s says that he didn't know, he couldn't really describe pornography, but he knew it when he saw it. Again, the idea is there is a nuance to these things as well as objective measurement, and it's okay to trust your nuanced assessments. I put out this just to show you this picture, which makes me laugh. These canned photos are just hysterical. 5 presumably healthcare professionals all doing different things. This guy here in the middle is looking to the guy on the side, engaging whatever conversation they're talking about. Perhaps it's because the Suns lost last night. The girl with the one pencil is trying to get the attention of the guy in the middle, but I'm not sure very successfully. This girl over here with the pencil is looking down at perhaps a note, but not really sure, not sure she's catching what he's saying to him. And of course, me standing over here is clueless, unconnected to anybody, and pointing to perhaps a food stain on his coat. I'm not really sure what's going on there. Just thought that was kind of funny. So You'll hear terms bandied about. The program directors of the various residencies, at least in medicine or in physician training, are very familiar with the ACGME, and ACG came up with years ago, quote unquote, the milestones, which are measurable markers of progression of competence. And you'll hear terms such as medical knowledge, patient care, problem-based learning, systems-based practice. Those are fine. And those practitioners and teachers that are involved in progressions committees are more facile with these terms, but they are markers of competence that they're looking for that happen over a particular time period, thus called milestones. Not asking you to be proficient in that necessarily, but to be familiar. And in fact, when you're doing evaluations of your learners, these terms come up, so you need to have some comfort in them when you're trying to make these assessments. But I'm going to talk about other tools that are being developed these days more so. So these are stages in the development of specific competence, what learners have learned at a particular time, a particular stage of development. And at the end of the day, what you really want to know, and certainly the public wants to know, is what can the trainees be entrusted to do, all right? Then the term is also competency. Competency and milestones are different, right? A competency is an actual ability of a healthcare professional using multiple components, perhaps of these sets of skills that describe to what level that individual has progressed. It is observable by a teacher, and it can be measured and assessed to ensure acquisition. So those competencies we'll go over a little bit more here in a minute. And then finally, and I know Cody Susek from the physician assistant program in Creighton went over EPAs in a recent TED Talk-like format. I'm going to go into this a little bit of a deeper dive today, because EPAs, these entrustable professional activities, are what's going to be used more and more, and are already being used in some training programs, as a more workable tool for teachers who are not entrenched in educational development, specifically what they do, to have them have a better feel as to how to assess learners. That indeed is what we're trying to do, is make it more practical for teachers to assess learners. So these are really units or descriptors of professional practice or work. In other words, these are actual tasks that have been deemed important for learners of different shapes and sizes, surgeons, internists, physical therapists, whatever, that they are able to be have learned enough to be trusted to perform unsupervised once they've been deemed competent. This is kind of the nuts and bolts of it, and it does make sense, and it is measurable. It's observable, measurable, and usually requires multiple competencies to make good. You have to have multiple skill sets, if you will, to ultimately have and be successful at an entrustable professional activity. So take home for today, number one, know what an EPA is, recognize the term, and that it will be coming into your neighborhood if it hasn't come into your neighborhood already. I throw in this KSA, knowledge, skills, and abilities, for two reasons. One is just to let you know there's another term that sometimes is used out there. Similarly, though, goes after knowledge and skills, but also incorporates attitudes, which is incorporated in these other EPAs as well, but this one highlighted it specifically. And remember that no matter what you use and whatever the EPA is covering, and there are different elements that we're going to talk about with EPAs that cover different skill sets, but all of them as practitioners, nurse, doctor, therapist, you name it, physician assistant, doesn't matter. If you do not have the ability to demonstrate you're capable with trustworthiness and self-awareness, everything else doesn't matter. These are the two foundational pieces that must be present in a learner in order to progress to anything, right? If you can't trust them as a teacher, that's a problem. If they have no self-awareness as to what their limitations are, such that they will appropriately seek help, that's a problem. These are two problems that are almost insurmountable if unable to be attained. Don't know how more strongly I can say that, but that is key. And the reason maybe I'm stressing it more is that recently we've had an encounter with a learner who has some skill sets that are pretty good, but has very little of these two, which is problematic. So that's a big warning sign. Okay, I'm biased. What I do is teach physicians, and it definitely is a work in progress. So I'm going to go over just a couple of different models, again, to make you familiar with different names of how it is that Teachers can assess learners to go from a very beginning stage to quote unquote an expert stage, and there's different tools that do that. The intent here is not to have you be expert in these tools. The Dreyfus model is one. There's another one by Dr. Noel Birch. I like this one because it's triangular, which seems to be pretty easy, and describes maybe how some of us feel after happy hour, which is to be unconsciously incompetent, or you become consciously incompetent, or you become consciously competent, or you become unconsciously competent. You're like, wait, my mind is spinning. What the heck are you really talking about here? The development I look at can be described this way from a learner's perspective. There's a learner doesn't even know what he sucks at. Okay, now they've progressed and learned enough to know what they do suck at. They now say, all right, I'm good enough now that I can do this task. It takes some effort, but I can do it, right? And you're assessing these as the teacher. And then finally, you get to the point where you're really doing things without thinking. Now, this isn't to say that you're being mindless, but you maybe are being somewhat effortless in your accomplishing whatever task it is. So this stepwise progression is essentially what's happening if we're doing the right thing for the learners. Miller's pyramid is similar to this. The Miller's pyramid you've heard about maybe if you've involved in yourself in anything with regards to education development. Again, what the learner knows, some facts, but really doesn't know what to do with them, now knows how, so does be able to put some of these facts into context, shows how, is able to demonstrate, this is an observed structural clinical exercise, OSCEs as people remember, and show some competence, and then actually is able to do in real life and be able to show that to the educator, etc. So knows how, shows how, and does. And the reason I've reemphasized that is there's a fifth part here that goes into this play as well. So knows how, shows, and does. But a big part of this also is attitudes and what I would call behaviors. And that's probably part of the fifth part of the triangle, which we'll mention here in just a second. Again, all of these are developing slowly or fast, depending on the pace of the learner, over time. So there's been discussion on those who are fans of Miller's pyramid to say that, knowing what you're doing what you're doing, showing what you're doing is all fine, but also there's a component of is, a self-actualization, if you will, that is above and beyond just the knowledge and performance assessment exclusively. In other words, what does it mean to be what it is the end goal is for the learner, a physician in this case, or a nurse, or a therapist, whatever. And so you really need to, as you're making these assessments of knowledge and of clinical skills, also make sure that you're assessing and as needed teaching proper professional behaviors. Again, gets into that more nuanced piece sometimes, I think, for older teachers in particular, that the part of a professional is actually the humanistic part, which is very, very important and they cannot be successful without at least that piece. All right, so let's go back to EPAs here real quick. Let me move this over for just 1 second here. Thank you. So EPAs, again, allow faculty to make competency-based decisions on the level of supervision required by the trainee. We've talked about the competencies of the ACGME, but those collectively constitute a framework that describes quality of professionals, i.e. they're self-directed learners, they're professional, they have a good knowledge base, et cetera, et cetera. So these are all helpful, but the key is you want to incorporate them into a structure that allows you to see if that learner can actually accomplish actual clinical tasks. Do these frameworks translate into the world of medical practice? And they are really conceived to translate competency frameworks into observable tasks, responsibilities, or behaviors. Okay. Oops. So think of EPAs as a way to translate competencies into clinical practice. Competencies are descriptors of healthcare professionals, but the EPAs are descriptors of work. So what it is, it makes up practitioners, but then how do they actually apply it clinically? And it often takes multiple competency domains to do that. All right. Should get my finger to work, right? So let's go through an example here. An example would be for a practitioner, physician in this case, recommend and interpret common diagnostic screening tests. So to be deemed as able to do that independently, to be entrusted to do these tasks, one would have to be able to show that they can use evidence-based and cost-effective principles, they provide rationale, for why they do what they do. They interpret the results of the basic test. They understand the implications and urgency of abnormal results, and elicit and take into account patient preferences. Again, the personal, professional component here. So these are your guardrails, as it were, that you're looking for a learner to become entrusted to do something such as, in this case, recommend and interpret diagnostic and screening tests. Jeez. So let's go over somebody who's pre-entrustable, if you will. For example, a student goes to see a patient, a woman, in fact, who's unable to get comfortable. She has a lot of abdominal pain. The student presents the history, the physical exam, happens to miss the urine pregnancy test and subsequent beta-HCG and elevated alk phos, but does note that the person has leukocytosis. Patient reports, the student reports that the patient was at a picnic earlier, so the student thinks that we'll need a stool sample to rule out food poisoning. We can talk about the disconnect there. And the student's recommending a CT with contrast, a CA-125, CNP lipase amylase. I'm not going to go into all the details of those tests. But the point is the supervisor recognizes there's a very disjointed, unentrustable learner with regards to appropriately assessing and testing this patient with the symptom complex they presented with. So they talk about the caution with radiation in women of childbearing age. You probably should make sure the person is not pregnant. The use of a screening test such as CA-125 is not appropriate, etc. So this person is definitely not ready for prime time, for lack of a better term. All right, let's take what happens if they are better at this. Oops. So the student encounters the same patient with abdominal pain, gets the history and physical, but this time the student asks the patient what the patient thought was going on. By the way, that is a great tool to impart upon your learners, is to engage the patient in what they think is happening. Doesn't mean they're going to cough out the diagnosis, but as I've often said, patients are telling you what's going on if you just engage them. And yes, it doesn't mean you have to ask open-ended questions for everything like they usually teach you in school, but it's not good to do all the time. But engage the patient in what they think is happening, because sometimes they're on it. Student notes a positive pregnancy test and thinks now that ectopic pregnancy may be in the differential. Also notes the elevated alk phos and white count, so adds gallbladder disease to the differential, and now recommending some imaging such as ultrasound and not CT as an initial imaging event, as well as being concerned about radiation to the fetus, etc. So the point is you can see the difference between somebody who's becoming more entrustable because they're thinking more broadly and discreetly and behaving with those guardrails as initially would allow them to be entrustable versus the one that's not. So that's an example. Again, it's not milestone-based per se. It's just this is what is necessary for the learner to show that they're progressing, almost getting ready to be entrustable with an assessment of a patient presenting with abdominal pain, at least in this kind of circumstance. So that's one option. All right. Here's another EPA, and you can have as many or a few EPAs as you want. And I can tell you that different disciplines are coming up with EPAs that are necessary for residents in training or therapists in training or what have you. So you'll be seeing this more and more. This EPA is in assessing the entrustability of a learner to collaborate as a member of an interprofessional team. Everybody's talked about IPE. Yes, it's important, but what exactly do we mean by that, and how can a learner demonstrate that such that they are on the road to becoming entrustable? So we know that effective teamwork is necessary to ensure safe care. Recognition of the roles and responsibilities and contributions of all team members is understandable. Identifying those team members and responsibilities is important for a learner to do. Be respectful, appreciate communications, understand your own limitations. And you'll hear one of my favorite phrases when it comes to that place. And again, this goes back to one of those two things about trustworthiness and self-limitation recognition. And recognize teamwork. Remember, teamwork makes the dream work. It's one of my favorite states. Just like that. So, an example of a pre-entrustable learner when it comes to the IPE part of life. So a student, for example, is assigned to a team and he shows up 5 minutes late per rounds. Student says the telemetry checker wouldn't let him review telemetry strips on his patient admitted with syncope. Quote, the student says, I can't believe she wouldn't let me see the tracings. I have no control over her, but someone should talk to her about her unprofessional behavior. Yowza, it's getting kind of zippy. His other patient that he was caring for was an elderly woman with urosepsis, and when asked on rounds how physical therapy was going, She said she hadn't had PT for the past 3 days. Student's comment was that he spoke to the therapist 2 days ago who told the student that the patient didn't want to have PT on the first day and wasn't in the room on the second day. Quote, no wonder this hospital sucks and has a bad reputation. No one does their job. Yows, this is really a tough attitude. Has anybody come across learners with this bit of attitude? I'm going to tell you in 35 years, the answer is yes, at least for me. And no wonder nurses feel so stressed. And if there's any nurses listening, I'm sure this is how they feel sometimes with jerks like us. So, how is it we know this learner now is becoming entrustable with regards to at least understanding the value of interprofessional cooperation? Same student shows up 5 minutes late for rounds, but instead explained that he had to wait some time for the telemetry tech to complete her handoff conversation before producing tracings. In other words, the student is demonstrating he understands that the tech has other things to do besides just cater to the student, and would give the handoff once, or would give the tracings once the handoff is complete. The student's patient with urosepsis, the student actually asked the patient how PT was going, and said, quote, I know you don't feel like PT. I know you didn't feel like PT a few days ago, and I know you've had a lot of tests that have resulted in not being in the room. I'm going to reach out to the therapist and see if we can coordinate things better. Doesn't that sound more appropriate, more professional, and more empathetic to the plight of the patient, which presumably is why we do what we do? So again, entrustable activity. Previous one, person definitely not ready for prime time. All right, a few quick warnings here. When you're dead, you don't know that you're dead. All of the pain is felt by others. The same thing happens when you are stupid. All right, maybe a pejorative kind of a bold term, but the point is that sometimes people just don't know what they don't know and how it affects others around them. Oops. So when you're assessing learners, there can be trouble ahead. Trouble ahead, as I kind of mentioned before, without those, the dangerous learner could be somebody whose confidence exceeds competence. I will say if there's anything you take home from today, which probably coming from me would be very little, but these are words I live by. Confidence exceeding competence is a warning sign in any learner. You've got to rail that in and understand that that can be very, very dangerous. So don't miss it. If you're with learners and they're nodding a lot but not saying a lot, that does not mean they know or don't know what's going on. You just don't know what's going on. So you need to prod them, you need to get something out of them, and if it needs to be in a smaller group, so be it. If it needs to be one-on-one, so be it. But that makes your assessment. You just can't say, well, I didn't know. I couldn't assess anything because they wouldn't say anything. Your job is to get it out of them. We don't always read our audience as well, so just remember that's a limitation, and don't assume somebody does, as I say, know or doesn't know something. Give enough time for one to think and be ready to frame questions in a progressively more challenging ways. Allow learners to gain confidence. I almost always, when I'm with folks, is start with very basic questions that I would bet the farm they know the answers to, even if it's somebody's age, the sex of the patient, something very basic, right? Just to kind of loosen them up, get them engaged, and recognize that it's okay to be wrong. Just go out there and try to say something. And it allows you to objectively assess the knowledge base and ability to reason, which are key components of progression. So again, the other thing I would throw out there for those of you who, at least from a physician perspective, and I know this is going to sound old school, but I think it's very important because I think we've gotten away from it with the advent of the EMR in particular, and sometimes with the pace of the patients we have to see in terms of volume. Rounding at the bedside is unbelievably important, not just to share physical findings and so forth, which of course is important, but it's to engage the patient in what it is you're doing. Patients never mind having people in there talking with them, not at them, with them about how they're doing. It's remarkable how much they really get a sense that the team is actually taking care of them. And it also puts you in a position to assess the ability of learners and how they've interacted with the patients in real time. Watch them interact, ask them, have them ask questions, etc. And it also allows patients to really get a feel that the team cares about how they're doing. People just want to matter. You need to allow that to happen. Okay, so a sufficient level of proficiency on multiple levels for learners. That's what we're looking at. So it's not just a milestone, it's not a specific fact-based assessment, but it's really the entire gambit of those EPAs we're trying to assess for learners, and are the learners gathering all that to become more entrusted, to be more independent in doing those skill sets. EPAs will likely to continue to become more ensconced, I haven't used that word in many years, in competency-based training. In other words, this is where things are moving towards. The ACGME went milestones, which is fine. They still use milestones, but they realize that milestones are clumsy for most teachers to use in the clinical setting. EPAs will become more the deal. Just because we've completed clinical training does not make us proficient as teachers. That's a fact. We're all put in the position sometimes to assume that people know how to teach. They don't. It takes time, and that's okay. Doctor, yes, I know, is derived from the Latin doco, which means to teach. I've been told that 50,000 times. I get it, but it doesn't mean just because the Latin word for doctor is dogo that it means you're a teacher. Okay, so it takes work, it takes interest, it takes time, it takes direction. Hopefully it takes some more feedback from all of us working together to make ourselves better at doing this. So today was meant to kind of provoke some thought how we can be more sure that learners are progressing as they should. It definitely takes a team. You are providing data points that will be part of a number of data points used by clinical competency committees or clinical progressions committees. But it's very important at what you do. And if you're not sure how you're doing what you're doing, engage those other members of the faculty that are a bit more comfortable with this, and don't just think like, well, I'm just going to give them all 5s on the evaluation or something like that. Okay, so that's kind of what I had in a nutshell there. Some references there, and if this is recorded, it'll be available to you down the road. But I will say the AAMC, the website, has some interesting work on samples of EPAs and kind of discussions about EPAs, which is very, very good. It's a long document to download, but it's actually very, very good. So I'm available for any chat-related questions or those that go to Jessica and hit me.
Thank you, Dr. Wisinger, for your great presentation. And I love that it's not just about clinical supervision, but also about a learner's behavior and attitude. Super important as they're working with patients. One question that has already come in, and those of you that would like to ask a question, you can just put that on the chat and then we will monitor that. But the first question that came in, as you're talking about a goal being sufficient, can a learner be assessed as ready to progress at that stage 3 or that conscious competence level? Or do they really need to be at the top stage, really doing it without thinking in order to move on?
No, the doing it without thinking, the top of the pyramid, if you will, right, is really meant for somebody who's essentially ready to fly, if you will, right? So they've made it. So that really, that third box or third tier is really the person that's not ready to be totally independent, because independence is really what you're meant for people you think are ready to graduate, if you will, right? They've accomplished all those tasks to the level where they're ready to be at the quote next level. So that is really reserved for people who are entrustable, right? They're entrustable, basically able to do what they do. Now, to be very honest with you, if you think about it, you know, when students come in as residents, for example, for medical school, there is an assumption that they are capable of performing history and physical exams at an entrustable level, right? That, as you're really paying attention, is not necessarily true. So it behooves us to really observe that. And yes, although schools are essentially attesting to the fact that that fourth year student has now reached that level, has graduated medical school, is showing up to do residency training, and it can, quote, at least do an H&P. I would put it out there that it may or may not be the case. So I'll leave it up to you as residency directors and as teachers within residency programs to do that. But my sense is, I'll give you an example. About 5 or 6 years ago, we had an individual come who seemed to have great difficulty in correlating, you know, physical exam findings with what was really happening. And then it turned out, as the patient or the learner was observed doing a physical exam, really wasn't very comfortable doing what he needed to be doing. So the point is that the apex of the pyramid is really meant for those that are ready to be independent at that particular competency, at that EPA. Does that make sense? Okay.
Great. And the next question is, how do you suggest bridging that gap between graduate student into a learner that is going into their first year residency when they are very used to performing at an extremely high level. It's usually why they are where they are at. And then trying to bridge that between student and resident.
If I'm getting the gist of the question is that how can you, somebody going, let's say, from school X to residency Y, right, is, as I said before, presumed to be ready to be at residency level Y, okay? I got to be honest with you, you can puddle along and just see if it's happening the way you think it should happen. I personally tend to observe people, perhaps not with the intent to demean them or to question them, but just to kind of observe them, such that I begin to have comfort that they know what they're entrustable with the activities that we presume they have attained. Does that make sense? In other words, if you really think about it, I mean, just think about this. Think of the thousands of people that are graduating from school every year that presumably have been checked off as able to do the basics with regards to patient assessment. And I think most of them probably are. Some are better than others, but they at least are at the basic minimum. But, you know, that's not, I'll be honest with you, it's not universally true. Learners can get by oftentimes because so much is put on evaluating them based on what they show they know, objectively, right? In terms of testing, in terms of answering questions, etc. But really, the way they deal with patients, the way they touch patients, examine patients can be highly varied out there. And I just think it's worth it for the patient's sake to have comfort that they're sure what they're doing. And the ways I do that are not just to put them on the spot and say, let's see what you can do. I'll kind of go in the room and on rounds even say, let's just kind of assess, what do you think of the lung exam, heart exam, whatever. Let's talk about the questioning of the psychosocial dynamics of this patient. I kind of do it, and they may totally know it and nail it. We're good, we're done, I'm happy, everybody's good, and they may struggle. That's where you're going to figure it out. So I don't assume. Maybe it's part of my trust problems I have in life, but that's just how I am. So long answer to your question, but the point being is that it's reasonable to have some degree of trust of where they're coming from school, that they're ready to do some things, but I would be cautious about it, I guess. Remember that often what determines people graduating school is, you know, a series of successful evaluations from their clinical rotations, of which can be all over the map, right? They may have followed 2 patients in a rotation, they may have had 10, who knows what. But often it's the USMLE scores, right? And the fact that, and that's it. I mean, that's basically it. So it really takes somebody notably bad not to graduate, with all due respect. So it's a mixed bag, I guess, is what I'm saying.
That's good instruction there. Thank you. Any other questions? I don't see any others besides those 2. Anything else you want to conclude with, Dr. Wisinger?
Yeah, I'm also sad the sun's lost too, for whoever was saying that. But no, I think that, like I said, keep your eyes open for entrustable professional activity. That's going to be happening more and more over time. It's already started. I'll give you an example in gastroenterology fellowship training. They've already got EPAs set up now for fellows in different levels. You're going to see this happen more and more. And I think it's much more practical and usable for teachers of learners to have an idea as to making sure that the collection of skill sets is being met by the learners in a way that is understandable by both parties. Not trying to diss the milestones. I think they have their role, but quite frankly are not very usable all the time. So stay tuned for that. And I know from our group's perspective, faculty development, we're going to have some more discussions on this as time goes by, particularly as the year progresses. So yeah, thanks.
For sure, and I do want to bring up, I know you talked about it, about the short video vignette that Dr. Shashik did for us last month. Just a short, less than 15-minute video on those EPAs. So maybe that's something I can, again, add to the email communication as we get that out next week. So just a reminder, first of all, thank you so much, Dr. Wisinger, for your presentation. And then also the email will be coming out by early next week with the CME instructions so that you can get credit if you would like that. Also with the recording, and then I will add Dr. Shashik's EPA's video and also the PDF of the slides that Dr. Wisinger just presented. So thank you so much for your participation, and we will go ahead and stop the recording.